we did case 2.
Gotcha.
All right, I think we have most of the people here already, so we can go ahead and get started. Just a few things before we do get started. So after this session, I want you guys, if you can, to do the post quiz, but make sure that you do you go to yesterday's live streams and watch one of the ones from yesterday to get the information that you might need for the post quiz. Probably the last one that was streamed, I think that's Residence 8. Watch that one because it has most of the information that you're going to need, and it'll be a good review as well. After you're done with that, go and take the post quiz. We're going to probably have a session over YouTube going through all the answers. I believe we're going to aim for about 2 o'clock Pacific time. So if you can do the post quiz before then, that's going to be better, so you can actually join in. If you can't, for whatever reason, don't take the quiz. I mean, you can take the quiz, but don't watch that session before you take the quiz, because I want this to be as unbiased or unaltered as possible, so I can gauge how much the growth was and see what I need to do to change my teaching style or anything like that. So don't watch that session, do the quiz, and then if you can't make that live session, go ahead and watch it later on after you take the quiz. Does that make sense to everybody?
Yep.
Cool. All right, so let's get started. So it's going to be similar to yesterday, where we're going to have a case that you don't know everything about, but you know a good amount of. And you are going to kind of lead the discussion. So I'll call on you guys and ask what you want. So we have a 35-year-old female with no chronic medical conditions who came into the ER with chest pain. So right off the bat, Dr. Ashna, what's important to note with that first statement, that she's a 35-year-old female, no chronic medical conditions, and she's coming in with chest pain?
I would say, well, like, I mean, right off the bat, I guess, if a patient came in with chest pain, I mean, you could assume that it had to do something with the heart, or like something like that.
Maybe. So what about her age? She's 35.
Right. Yeah. Like, I mean, unlike someone like who's old, who might be prone to like more more like heart conditions, she is pretty young.
Yeah.
So I'm getting. Oh, yeah. Sorry.
No. So I was just gonna say, if we have a 75-year-old with a history of coronary artery disease, that's going to be somebody that's going to be most likely to have, a heart attack or something else going on.
Right.
Versus a 35-year-old, you're right, she's very young, and so your suspicion is going to be lower, but you're going to have to take it in context of everything else. So if I told you she's a 35-year-old that had her finals recently, or just got out of a bad relationship, or broke up with her boyfriend of 10 years, are you going to be as suspicious for like a heart attack, versus what else would you be suspicious for?
If it was based more on stress, then I feel like it would be based on anxiety. So could be tachycardic, and that could lead to like heart problems. It's not necessarily like based on like other conditions that's like not related to
Yeah.
something like that.
So exactly. So she's young. She's lower risk in general. So we're gonna. I mean, we can't rule it out. We can't completely rule it out, but as far as like dangerous cardiac or pulmonary issues, but she's on the younger side. So keep that in mind. All right.
Yeah.
So Dr. Upal, what do you want to know about next?
I would probably ask about the condition of the chest pain, like when it started, if something makes it better or worse, the quality, like if it radiates anywhere, if it's constant or is intermittent.
Good. So that whole OPQRST thing, right? So the pain was sudden, and it began 3 hours ago. At that same time where she was having chest pain, she had associated shortness of breath. And the shortness of breath and the chest pain have been constant since the onset. Nothing has really made it better. It's pretty severe for her, so nothing's really making it worse. It's located in the lower left chest area, and it's not radiating anywhere. She says it's the worst pain she's ever felt, so she's not able to really give a rating to it. Anything else you want to know?
I guess like what she was exactly doing when the pain came on. So if it was maybe exercise induced, or if she was just sitting and it started.
Yeah. So what happens if I say she was walking or running and then she started having chest pain?
I would think it would be more cardiac related, or more a sign of an MI or maybe angina, which probably would be resolved if she rested. But if it was more sedentary, that could maybe tell me it's a little more serious, since it's not exercise induced.
Yeah, and it would be weird if this was exertional chest pain, right? Because she's so young. So yeah, but I definitely agree. Chest pain that gets better, worse with exercise, better with rest. You always want to think of a cardiac issue like an MI or angina. So yeah. So she was watching TV. She wasn't doing anything. She was sitting down, and when the pain began. So good. So Dr. Bailey. Oh, we have two Baileys. Dr. Bailey W. So she's been on spring break for the last week, and so she's been mostly home, sitting and watching TV and movies. So why is that important?
So it sounds like she's mostly sedentary then, which could potentially lead to DVT. I'm not sure if just sitting at home and watching TV would be enough for the clot to form in the legs, but it's a possibility.
Yeah, so let's think about that a little bit. So she's sitting at home watching TV. I mean, you hear about people live streaming on Twitch for like 36 hours, right? Having these massive marathons. So yeah, that definitely can lead to being so sedentary that you can form a DVT. But I mean, if she's watching TV, she's probably getting up to go to the bathroom, or even let's say she's been sitting for 10 hours straight. Is that enough to form a DVT?
Probably not.
Probably not, but we don't know.
Yeah.
Right? So if we think about how long we sleep, some people sleep for 10 hours a night. If they're completely still for 10 hours a night, do you think that everybody who sleeps that long is forming a DVT? Probably not. So what if I say she was on a plane and she had just come back from London and that was a 10-hour flight? Is that going to put her at risk?
I'd say yes, just because the way you sit on a plane, there'd probably be less circulation.
Yeah, you're kind of compressing that vein by sitting down, and so even decreasing the flow even more. And if she doesn't get up or anything like that, then yeah, potentially. So good. So all this is to say, we don't know. Maybe it does put her at risk, maybe it doesn't. But good job. And so I also say she was on spring break and been mostly home. So why is that important? So just a note, I did change. So these cases are based off of real patient, so the information is changed. And so I actually changed a little bit of the information that I gave you initially. So for instance, in this one, she's not an architect. She's actually a school teacher. So that's kind of what I was getting at, that she's been on spring break. So if she's on spring break, you have to think, is she in college? Is she a teacher? Something like that. But what about the fact that she's been mostly home?
I'm not too sure. Perhaps it has something to do with her home environment.
Yeah, who's around her at home. Also, Dr. Pointer's saying that it can indicate less stress and anxiety, which is definitely true. Although, who knows? Who knows who's with her at home? And then Dr. Paul is saying less contact with people, which is also definitely true. So good. All right. So 3 days ago, she began to have a cough. So the other Dr. Bailey Teza, what do you want to know about her cough?
I want to know if it's productive or non-productive and how long ago it began.
All right, so began 3 days ago. It's non-productive. What else do you want to know?
Has she been having fever and chills? And are we looking at the same chest X-ray for this patient?
We are looking at the same chest X-ray, but we haven't gotten a chest X-ray yet. So she did have fevers and chills this morning, and the highest fever was up to 101.4. Anything else you want to know about this patient, the patient's cough?
History of smoking?
Yeah, so does she smoke? Which she does. She has a 20-pack year history of smoking. She's trying to cut down, and she's down to about 5 cigarettes a day. What about if I said that it was a productive cough, what would you want to know after that?
What type of mucus is coming up?
Yeah, so what the color of the mucus is. What about blood? Is that going to be important?
Yes.
Yeah, so she's non-productive, so it doesn't matter. But when we think of a cough, we want to ask to make sure that it might not to ask if there's blood, because that can indicate something like cancer, TB, a really bad pulmonary embolism, something like that. So good job. Okay, and so the patient also admits to right leg swelling that she noticed yesterday. She has no trauma and has had some discomfort in the leg, but no real significant pain. She's attributing it to the lack of exercise over the last week. So Dr. Rebecca, talk to me a bit about that statement.
Yeah, so the swelling has me worried for either a D or pericarditis, because to me it's indicating that she's not getting good flow to her extremities. So that's what I'm thinking right now.
Mm-hmm.
To check for those things, I want to see her D dimer. That would tell me if she has a blood clot, and that could rule out DVT. And then I want to also check her troponin levels to see if it's not that, then it's a heart issue. And going off of that, I would see what I could further do.
Okay, so yeah, a few points there. So the D dimer is a good thought, but whenever we're trying to decide what we want to do to work up like a DVT or a PE, we have to look at the whole context, right? So if your suspicion is super high for a DVT or a PE, then doing a D dimer is not going to help us, because it's probably going to be elevated. And if it's not elevated, then that's really weird, and it might not help us, especially if your suspicion is super high, if she has other signs of a DVT or a PE. Now, for the troponin, definitely anybody that has chest pain that has like a suspicious kind of like.
You just cut out for a second.
Okay. If they have a suspicious history, then you definitely want to get a troponin. And then you had mentioned that it's a decrease in circulation. So I wanted to clarify that it's not a decrease in circulation going forward. So it's not the heart being unable to pump blood to that extremity. It's that inability for the blood to come back to the heart, right? So if there's a clot there, that's going to prevent the blood from going past that clot, so it can't return to the heart. And so the issue with that it does cause some leg swelling, but the leg swelling is not going to kill you. What can potentially kill you is if that clot gets broken off and thrown up to the lungs. So, but yeah, good thoughts. And so you're right. We would want to make sure that there's no DVT or anything like that. What if I told you that she's having some leg pain, she's having a little bit of swelling, but it's more in the front of her leg, and she has a kind of a red patch on that leg that's really tender to palpation? What would you be thinking of?
I'm not quite sure. You said it's a red patch. It's on the front of her leg.
Mm-hmm.
I would want to know how long it's been there and if it's
Yeah.
causing her pain.
Yeah, let's say it's been going on for like 2 days. People in the chat are helping you out.
Okay. And yeah, infection.
Yeah, so what is that called if you have a skin infection?
I'm not sure what exact word you're looking for.
It's okay. So Dr. Paul's saying shingles. Shingles, definitely, you can have that rash and that dermatome of distribution. It's like vesicular. It's kind of like fluid-filled bubbles almost. Or the one that I'm looking for is cellulitis. So cellulitis is an infection of the skin caused by usually bacteria, and it can cause pain, swelling, and redness. A lot of times it's even in the leg, but you can have it anywhere. But yeah, good job. All right, so we say that she admits to cough, chest pain, shortness of breath, fever, chills, leg swelling, palpitations. So we kind of have all of that. All right, so we'll go with Dr. Sexton. So she has no significant past medical history, but she does have a history of an incidental murmur found when she was a child. Echo at that time showed that she had a small atrial septal defect. Her cardiologist elected to monitor. So what do you make of that history?
This could be important for maybe if she has like pulmonary hypertension, or that could result from the atrial septal defect.
So
or if it hadn't closed all the way.
Okay. So how does an ASD cause pulmonary hypertension?
The heart has to work harder so the shunt created by the ASD causes deoxygenated blood to return to the deoxygenated side.
Yeah, so that part isn't as significant. It'll be significant later on, but with an ASD, so the left side of your heart is a low pressure system. It's not having to push blood to the rest of your body, it just has to go to the lungs. The left side of the heart is a higher pressure system, so it has to pump blood to the rest of the body. So when you have a higher pressure on the left side, and you have a hole between the left and right atria, so the top of the heart, as you try to pump blood out, some of that blood is, instead of going out to the aorta, it's going to go off to the right side. So over a long period of time, after you start to pump more and more blood to that right side, you're going to have more pressure on that right side. So that right side is going to have to adapt. And so you're going to end up having a system where the right side is a higher pressure system than it should be, and you're causing pulmonary hypertension. You're causing increased pressure to the lungs. And so that causes a lot of issues going forward. One of the biggest ones, though, is if your right side of the heart now has a bigger, more pressure than the left side, you're going to start filling the left side with deoxygenated blood, so blood that hasn't reached the lungs and gotten oxygenated. And so that would cause a lot of problems going forward. So that's important to know. But there's another reason why this is important to know for this specific case. Do you know why that might be, Dr. Sexton? And Dr. Paul, yes, it can lead to heart failure.
I'm not specifically sure.
What if I told you that the patient, instead of having chest pain, shortness of breath, now they're having left-sided weakness and numbness on her entire left side of the body?
Could it be due to maybe like a stroke or aortic dissection?
Yeah, a stroke. So why would she have a stroke?
from the, I'm sorry, I'm not entirely sure. Something with the pressure systems.
No, it's okay. This is a hard question. So you have a blood clot. Let's say you have a blood clot in the leg that gets thrown off, right? Typically, we would see it go to the lungs, causing a pulmonary embolism, right? Because that's where everything leads to. But we have an ASD. So how does that change things? So
it causes the clot to travel more to, like, it can skip the lungs.
Exactly. So it can go through that hole, go to the left side of the body, not even hit the lungs, and instead be sent out to the rest of the body through the left side of the heart. And so it can go straight up to the brain and cause a stroke. So that's why it's important to know whether or not she has it, if the ASD is still present or what's going on with it. So how would you tell what's going on with that ASD?
Using, like, if you hear a heart murmur.
Okay. What imaging would you be able to do?
An echo.
Mm-hmm. An echo. So an echo would be helpful in determining how the ASD is. Good. You had a really hard question, so I appreciate you sticking with me. All right. So Dr. Guerrero, the patient is on Ocella and prenatal vitamins. Why is that important to know?
With prenatal vitamins, we know that she's probably pregnant, since prenatal is commonly used for pregnancies.
Okay.
And Ocella is a pregnancy prevention.
Okay.
Oh,
Keep
going. You can go.
So if she's on Ocella and that's an oral contraceptive medication, and she's taking it consistently, is that going to be? Is it likely that she's pregnant?
Probably not. If she takes it constantly, she shouldn't be pregnant.
Yeah. So probably not, though we don't know and we can't rule it out. So the day that you say no, she can't be pregnant, is going to be the day you have a pregnant patient on Ocella, or on any contraception. So that's definitely good to keep in the back of your mind. But the prenatal vitamin for her was more because they were going to start trying to get pregnant. And so as they, when you are planning to get pregnant, you're going to want to start taking prenatals before. I think for her, she hadn't started and she was using contraceptives because she was smoking, and she doesn't want to expose the baby to that risk. So what about the Ocella is important?
Since you know that she's smoking, one of her side effects is blood clots, because it is prone to having blood clots.
Yeah, so Ocella in general increases your blood clot risk. It's not significant, it's not super high, but when you couple on smoking with oral contraceptive, you're asking for a blood clot. Your risk is way higher. And so she's having this leg swelling, she's on Ocella, she's smoking, she's sedentary. That's kind of setting up the perfect storm to having a blood clot. So yeah, good job. Do you know why Ocella increases the risk of blood clots?
I'm not entirely sure.
Okay. It's basically the estrogen. So the estrogen component increases your risk of having clots. And it's a whole mechanism that if you guys are interested in, send me a message. I can send you the pathway. But all right, good job. So let's go with Dr. Brinkley. So the patient lives at home with her husband and 3 children. She's a high school teacher and the husband's a physical therapist. What about that's important? Let's go with Dr. Mitchell.
Hi, can you hear me?
Yeah.
I would say, so she's living at home with their husband and 3 children, so maybe she also has to do a lot of work at home, like caring after 3 children.
Yeah.
And a whole family. And then you said she usually works as a high school teacher, but they're on spring break, so she's not as active as she usually is, probably.
Okay, good. Anything else in there? Her husband is a physical therapist, so why is that important?
So he probably has knowledge, like some medical knowledge that he might have provided her or could provide the doctor if he came in with her?
Yeah, I mean that's good. What do physical therapists do? Do you know?
They kind of help with rehabilitation.
Okay, so when somebody's rehabbing and you're helping them rehab, a lot of times it's done in person, right? And so, what is he at risk of?
Like, are you talking about in terms of if he had or if she had like an infection or something and he was around her?
Yeah, exactly. So, what infection are we talking about specifically?
I'm not sure if you guys talked about it earlier. I joined kind of late, so
It's okay. What's going on right now?
So right now we think that she has like a blood clot.
Or like the reason why we're doing all this virtually. What's going on?
Oh, sorry. Coronavirus?
Yeah, COVID. So if the husband is a physical therapist, he's in close contact with other people, he can potentially bring back COVID. But let's say he was at home for the last 2 weeks. She's been on spring break for the last week. And then the kids have been home as well. Is it likely that she has COVID?
I don't think so. Not if they all were adhering to like the quarantine rules.
Yeah, potentially. But what happened over this last week when we looked at the people that went out for Memorial Day? What are we seeing in the country right now?
But we're seeing more spikes than coronavirus cases.
And why is that? What's the incubation period for COVID?
Is it 2 weeks?
2 weeks, exactly. Good job. So you have a 2-week incubation period where you can have up to 2 weeks. You can have no symptoms. A lot of times you see it about 5 to 7 days, but it's up to 2 weeks. And she's been off of school for about a week. I think for her, she was doing stuff virtually, so it didn't really matter. So, but that is something to consider for sure. So good job. All right. Let's go with Dr. Pointer. Anything else in her history you want to know about?
I probably want to know more about like the mother having diabetes, and if there's any family history with that.
Yeah. So if her mom has diabetes, it puts her maybe at an increased risk for diabetes. And so she doesn't have a history of diabetes though, but it's going to be something good that you're going to want to check on and see. And probably do some lab testing while she's here in the hospital. What about her social history? So she has a 20-pack year history of smoking we talked about. She's trying to cut down. Anything else that you'd want to know about?
I guess you could ask about any further alcohol or drug consumption if that's something that
Yeah, so she drinks about 2 to 3 glasses of wine a week, and she used marijuana in college, nothing recently, and then uses CBD oil sometimes to help her sleep. So nothing out of the ordinary, but if she were using like cocaine or something like that, then that can increase your risk of having like a heart attack. But so it's good to get a drug history. So Dr. Sexton's asking, has she traveled recently, like more than 2 weeks ago? I don't believe she did. And Dr. Shifa's asking any recent surgeries. Dr. Pointer, why is it important to know if she had any recent surgeries?
This is just from like a general knowledge. I know that if you don't like partake in like the correct rehabilitation process after surgery, you might have an increased risk of things like blood clots if you're like not around enough or whatever.
Yeah, and so yeah, that's definitely important. So like she had a knee replacement and she's immobile for a long period of time. Definitely it's going to increase her risk of blood clots. The other one though is whenever you have a surgery or any type of cut, your body's going to be more prone to forming a clot because it's going to try to plug up that hole, right? So and so you have that state where you're going to have a more likelihood of clotting. So it's going to be important to know if she had surgery. She didn't, but it's a good thought and a good thing to know about. So good job. All right. So let's go with Dr. Hannah. So I'm going to give you her vitals. So her blood pressure is 102/59. Her heart rate is 110. Her respiratory rate is 22. Her temp is 101.6. And her O2 sat is 97% on 2 liters oxygen. What stands out to you? All right, let's go with Dr. Roshni. What stands out to you in those vitals? And if you need me to repeat them, let me know.
Could you repeat it?
Yeah, so blood pressure is 102/59. Heart rate is 110. Respiratory rate is 22. Temp is 101.6. And O2 sat is 97 on 2 liters oxygen.
The temperature is a bit high.
Yeah, so her temp is high, so she has a fever. So some inflammatory process going on. What else?
The blood pressure is below.
The blood pressure is a little low. The BP for women sometimes is on the lower side. So what you would want to do is look back at her previous blood pressures in clinic and see what she normally is. For her, this was around her normal. But if her blood pressure was usually like 130 to 140, like systolic, then this is definitely low for her. And you're going to want to keep an eye on it. But yeah, that's a good pickup. All right, so let's go with Dr. Garcia. What else in the vitals are standing out to you?
Well, I noticed that her heart rate and her respiratory rate are on the higher side.
So heart rate, respiratory rate on the higher side. So what does that mean? Like, what does that make you think of?
Hold on, I'm thinking. Sorry.
It's okay. You're allowed to think. It's okay.
Okay, I'm just gonna talk out loud. So her body's working harder to get oxygen going everywhere, right? That's why it's compensating and increasing the respiratory rate and the heart's pumping faster.
Yeah.
So maybe there's an issue with oxygenation somewhere?
I'm sorry, what was that?
So maybe there's an issue with oxygenation somewhere, and that's why it's working harder?
Yeah, so that's a good breakdown. So the heart is having a hard time pushing out enough oxygen to the rest of the body, so there might be issues with oxygenation. So the heart is beating faster because of that. She's breathing faster to try to get more oxygen in. So any pathology or any disease that can be caused by something like that can cause something like this.
Could it be like a pneumonia or
pneumonia? What else though? We're talking about what was that?
I'm looking at my notes. Could it? I don't think it's pneumothorax, but it could be.
Maybe. She has some leg swelling. She's having some shortness of breath.
Oh, pulmonary embolism.
Pulmonary embolism. Perfect. So good job. Dr. Awan, anything else in the vitals stick out to you?
I don't know, I couldn't hear it before, but she's also tachycardic. So her heart rate is elevated. I think getting an EKG could potentially, also like with her atrial septal defect, I think potentially getting an EKG could be valuable.
Okay. What about, and we'll definitely get an EKG, what about her oxygen saturation? Is that normal?
No, it's not.
Why is it not normal?
I believe it was low. I couldn't remember the exact number.
So she's 97% on 2 liters of oxygen.
Oh, that's pretty normal.
The percentage is normal, but is it normal for a regular person to be on oxygen? She's hooked up to a nasal cannula, and she has a normal oxygenation with that. So is it normal that she's on a nasal cannula?
No.
So what would we be normally?
What would be our normal percentage?
Yeah.
I think usually around like 99%.
Yeah, so you're gonna be high. You're gonna be anywhere between like 96 to 99. So the fact, and that's on room air, so without any oxygen. So the fact that she's on oxygen is super important because that tells us that her lungs are not compensating well. So something is going on there, so that she needs more oxygen going in to support that. So good job. So whenever you look at the vitals, make sure you take a look at the oxygen saturation, because if she is on oxygen, even if the number is normal, the fact that you're on oxygen is abnormal. So none of us, especially younger people, should be on oxygen. If you have COPD and you have chronic oxygen use, that can be normal for you, but it's still abnormal in that the lungs aren't really compensating well. So good. All right. So Dr. Dana, anything you want to know about in the physical exam?
For the physical exam, because previously she mentioned that her leg was swollen, I would test for, like, if the swelling is just limited to that area and look at, like, if there's any trauma or bruises that could have led to the swelling.
Yeah, so her right leg is swollen. It's swollen all the way around, and there's redness around the leg as well, and it's tender to the back of the leg. So what does that make you think of?
Since it's tender to the back of the leg, it can imply that it occurred because she was sitting down for a long period of time, like you were sitting down in a plane. And because it's not any bruises or anything apparent, you can rule out trauma based.
Yeah. So you don't always have to form a bruise, but yes, you're generally right. But like you're saying, you're sitting on a plane. So what would be the cause of having that tenderness in the back if you're sitting on a plane for a long time? We kind of talked about it a lot already.
Yeah, it could be like the limited circulation, for example, from a clot or from not getting enough oxygen going around in the leg.
Exactly, so like a DVT. So good. So Dr. Paul's asking if it's potentially an infection. And it can be an infection, but typically cellulitis is a well-circumscribed, or it can be well-circumscribed or not. So basically a patch of redness at some portion of the leg. Usually it doesn't go all the way around, but it can. It's usually red and tender to palpation, and it feels really warm. A DVT can also feel really warm too. The difference between a DVT and a cellulitis is generally the cellulitis generally with a DVT, it'll be pain in the back of the leg, even if you have redness all the way around. Cellulitis will be pain wherever that redness is. So, good. All right. So, Dr. Christelle, anything else you want to know about in the physical exam?
I know that a lot of the things that were mentioned already, they confirm pulmonary embolism because of the Virchow's triad. She had the estrogen therapy and inflammation. She did say no to trauma, but I would ask if there was any like congenital abnormalities.
Okay. So yes, definitely she feels a lot of Virchow's triad. But what about, so like if we're going to examine this patient, what would you want to examine? So we got the leg. What else would you want to take a look at?
I'd probably get a chest X-ray.
Or when you actually go in and listen to her, or I can't give it away, but when you go and examine her, what would you want to?
I would try to use my stethoscope and listen to her heart to see how the blood is circulating and if it's like working harder or not receiving enough oxygen.
Yeah. So you want to do heart and lungs. So, sorry, give me one second. So the lungs. So she was tachypnic. So she was breathing fast. Sorry, give me one sec. Okay. So she was breathing a bit fast. She had crackles throughout her lungs, but there were slight crackles, and she was resonant to percussion. So she had crackly sounds all around. When we tapped the back, it wasn't hollow. It didn't sound dull either. And she was breathing fast. And when we look at the heart, she was tachycardic. She did have a murmur. It was a harsh systolic murmur. which is typical for like an ASD. But her dorsalis pedis and radial pulses were intact. Her cap refill was less than 2 seconds. So, what sticks out to you in her physical?
I know you said that it didn't sound hollow, so that would make me rule out like fluid in the lungs. Especially, she also mentioned that her cough was non-productive. So
it would be kind of the opposite. So when it's hollow, it's kind of like a drum, right? So you're tapping, and it sounds like there's like a space between the lung and the chest wall, and that's more of like a pneumothorax, right? So you tap, tap, tap. It's hollow. Versus if you're talking about like fluid or something like that, it sounds more dull. But she doesn't have that, so you're right. You would be able to think less likely a pneumothorax, less likely like a solid pneumonia. Dr. Paul is saying crackles are sometimes indicative of pneumonia, so that's definitely correct. So you want to keep an eye on that. But Dr. Paul, her crackles are everywhere. So does she have a pneumonia everywhere?
That's less likely. I feel like pneumonia is usually consolidated to one part of the lung. Like you would see that in a chest X-ray. So maybe it's less indicative of pneumonia if the crackles are all over.
Good, but is there a type of pneumonia that can give you crackles everywhere?
I'm not completely sure.
Yeah, so pneumonias can be caused by fungus, it can be caused by bacteria, or it can be caused by what else? Dr. Bailey, what else can cause a pneumonia?
Virus.
A virus, yeah. So if you have a viral pneumonia, you can get that crackly sounds throughout the lungs. It causes kind of this inflammation throughout, and when you look at the chest X-ray, you don't see that solid consolidation. It kind of just looks hazy everywhere. So good job. All right. And then we talked about the murmur being typical for her ASD. And then she's breathing fast and her heart rate's fast. Okay, good. So Dr. Sharma, anything else in the physical exam you want to know about? So Dr. Anna. So we talked about most of it, but we talked about what the ASD can cause. As far as she had a clot and it kind of went up, and instead of going to the lungs, it went somewhere else. So what would you want to do to evaluate if she had any other issue?
Would it be looking at the echo or
on physical exam?
Oh, on the physical. I guess just listening to her heart.
Okay, so we did that. But what about we talked about if she had a DVT and instead of going to the lungs, it went through that ASD that she has and went to other parts of her body. So if we were to check for something like a stroke, how would we do that on a physical exam?
I'm not sure.
Yeah, so we would do a neuro exam, right? So we would test to see how she's moving her extremities. We would check her cranial nerves. Basically, the easiest way, especially if you have like belligerent patients or patients that are intoxicated or are not entirely with it, you just look to see how their hands and their arms arms and legs are moving. And if they're moving everything symmetrically, it doesn't look like they have any like tremors or like inability to kind of coordinate, then you can get a rough idea that it's probably not a stroke. But if we told her to lift up her arm, she's only able to lift up her right arm and move it, and then the left one, you bring it up and drop it, and it immediately drops down, those are like signs of a stroke. So for her, everything was normal, but because of her history, we want to make sure we do a good neuro exam as well. So good. All right. So Dr. Guardia, what labs do you want to get?
Can you hear me?
Yeah, I can hear you.
Sorry? Okay. Hi. Yeah, I want to get for sure chest X-ray.
Okay.
an EKG, and then maybe an angiogram or a pulmonary CT angiogram.
Okay, but before all that, what labs do you want to get? So like blood tests, like that.
Oh, okay. D-dimer.
Okay, so D-dimer.
And a white cell count.
Okay, good. So let's talk about the D-dimer first. Why do you want to get a D-dimer?
Because I'm thinking that she might have had a clot that might have moved, so I want to see if there's like fragments in the blood.
How suspicious are you that she has a clot? With all her history and her examination, how suspicious are you?
I'm not like 100%, but like maybe a 50, 60. Like she might have one.
Okay, so she has leg swelling. She has a history of smoking, and she's on a contraception. So all of that increases her risk. She has shortness of breath. She has signs of maybe a pulmonary embolism. So do you think that it would be 50-50, or would it be higher?
Yeah, it might be a little higher, yeah.
Yeah, so her risk is actually pretty high. So if we get a D-dimer and her risk is high and it's negative, does that help us at all?
No, you're probably right. It would just rule out just that it wouldn't be a clot at that point, I guess.
So typically the D-dimer will rule out a clot, but if it was negative, we can't really do anything with that because our suspicion is so high. And so we would want to go to a different test. So, and you mentioned it already, something like a CTA pulmonary angiogram. So good. And then the other thing you mentioned was a CBC. So the white blood cell count is 2.8, the hemoglobin is 13, and the platelets are 220. So what do you think about her CBC?
You say it was 2.8?
Yep.
Isn't like a normal like a six around there? So this would be kind of low.
So the normal's high, it's higher than that. So
yeah.
So she has a low white blood cell count, right?
Yeah.
So why is that important?
It would be like a sign of like an infection or something like that.
Yeah, it could be a sign of infection. What type of infection?
Well, I was thinking earlier that she could have contracted COVID. So
yeah, exactly.
A viral infection, yeah.
Yeah, so viral infections in general can cause bone marrow suppression and cause your white blood cell count to be low. Can you think of any other virus that can cause low white blood cell count?
I forgot which one I was thinking of either. I was thinking before it could have been any of the SARS, but I forgot the name of the other one now.
People are helping you in the chat, so
like autoimmune or
maybe
HIV.
HIV and AIDS, yeah. So HIV is going to attack your immune system and cause you to have a low white blood cell count. So that's good to keep in the back of your mind as well. But you're right. So you're thinking COVID before. So what would you want to do to check if this is COVID?
Well, besides the COVID-19 test, I would have probably rather take one of those. But I would want to really look at her lungs more than anything. That's why I wanted the chest X-ray, because pneumonia is a common symptom or a common sign of COVID.
Yeah, exactly. So we would definitely get the chest X-ray. Her COVID was positive, so she was COVID positive. And then for the sake of time, I'll kind of go through some of the other labs. Her BNP was completely normal. So her sodium was 139, her potassium was 4.2, chloride was 100, bicarb was 19, which is a little on the lower side, but it's not really too significant. Her BUN was 15, and creatinine is 0.65. She also got an AST and ALT, which were both normal. And those are the liver function tests. Anybody know why that's important to get?
I'm assuming the liver would have been like the way she processes her sugars, right? So she might not be, she might not be processing it well. I would have assumed that maybe she had diabetes as well because her mother had diabetes. So looking at her liver would have been good for that.
Potentially, it would be more the pancreas, not so much the liver. But even then, like the testing for that isn't really testing the pancreas or the liver. But with COVID, it can actually affect the liver as well. And people that have elevated liver enzymes, they have a harder time getting better. Hers were normal though, so it was a bit of a harder question. So, but yeah, and then they did get a D dimer and it was elevated. And then they got a BMP also, which was normal. And then her pregnancy test was negative. All right, so Dr. Chitwan, can you interpret her EKG for us?
Sure. So you want me to interpret it from the case material that you gave us?
Yeah.
Okay, so from the little I looked at it, is there an ST elevation on there?
No.
No.
No. It's the one that was in the case. It does look. I can maybe tell what you're looking at, but it's not an ST elevation. Because if you look at where it changes from the S wave to the T wave, that point is at the baseline. So it's not an ST elevation. That's just the way that the T wave looks. Is this a fast or slow rhythm?
I would say fast, because her heart rate was high. So I would say that EKG also is evidence for tachycardia.
Yeah.
For her
So
being
exactly.
tachycardic.
So really, this EKG just shows mostly sinus tachycardia. So she's just beating really fast, and which is what we kind of know from the history as well. Good. What about the chest X-ray? Anything you saw in the chest X-ray?
Yeah, the chest X-ray. What kind of got to me was the fact that the curvature on the top of her left lung, and then there's also certain fading, like less lung tissue density that you can see on there, which is kind of indicative of a pneumonia, and I guess there being pus present in those parts of the lung.
Maybe. When I looked at the chest X-ray, it just looked really hazy to me. Especially at the top. If you look at the right top of the lung, it looks kind of hazy there. It doesn't look quite clear. And as you go out to the chest wall, it looks a little bit more hazy. And it's hard to tell. Honestly, if I looked at this just really quickly, I would have said it might have been a normal chest X-ray. But if you take a close look, the top of the lungs seem a little bit more hazy. And so the read was multiple faint alveolar opacities are identified, predominantly peripheral with greater involvement of the upper lobes. I wouldn't have been able to read that, so I don't expect you guys to be able to read that. Yeah, the patient is not intubated here.
But sorry. But what about the curvature, like that? Because like that little curve, which makes it. If I was to just look at the chest X-ray when I first looked at it, it seemed like the lung was a little punctured there. But like that's not normal, right? The curve at the top of the left lung.
The top of the left lung. I don't see what you're seeing. So if you look at what you might be looking at is the rib 1. So as the rib 1 comes down, it kind of comes down in this sharp C type distribution. So that might be what you're looking at. She also is rotated a little bit. So if you look at the patient's right side, it's a little bit higher than the left, and that's probably because the patient is rotated. It's not so much that that there's any like issues with the lung itself. Dr. Bailey's saying maybe tracheal deviation, but it's probably also because the patient is rotated. If you look at the trachea coming down, it looks like it's a little bit more on that right side, maybe, but I think that's more deviation. I mean, rotation than anything.
Okay.
Okay? All right. So, Dr. George, the lower extremities show evidence of a DVT when we got it. So what if the DVT, the lower extremity ultrasound, was negative? Does that change anything?
I'm sorry, could you repeat that question?
Yeah. So we got a lower extremity ultrasound and it was positive for DVT. But what if it was negative? Does that change anything for us?
It would reduce the chances that it's a PE.
Maybe. So that's a good thought, because if there's no clot there, then where did the clot come from? But the problem is when you have a PE, it's because that clot broke off and went to the lungs. So it's possible that entire clot that was there was sent off to the lungs. A lot of times not. A lot of times you just get a portion of the clot that gets sent off, but sometimes you get the whole thing. So it wouldn't necessarily change anything, and it's still likely that it was in the legs. But other than the legs, where else did that clot come from?
I'm thinking. I'm sorry.
It's okay. So it's going to come out from the periphery. So if it's not in the legs, where else can it come from?
The arms.
The arms, yeah. So it's going to be a good idea to take a look at the arms as well. Good. So the patient was, so we did get, like Dr. Guerrero asked, or Dr. Guardia asked, we did get a CTA pulmonary angiogram, which showed evidence of bilateral segmental pulmonary embolisms. So, let me see. Dr. Zachariah, what is your final diagnosis for this patient?
I think it's PE.
A PE, right? So we have evidence of a PE, so it's probably a PE, but is that the end of the case?
No.
What are we missing? What's something that we haven't really addressed?
The cause?
The cause, exactly. So what do you think is the cause of her pulmonary embolism and her DVT? Both of those.
Possibly COVID.
Why?
Because she was showing signs of infection.
Yeah. So she has COVID. So she's COVID positive, and there was an article that was put out. I forget when. It was not too long ago that COVID causes hypercoagulability. It causes you to have an increased risk of forming clots. And there was a article that from a doctor that was doing I believe it was a thrombectomy. So they were going up to the brain of a really young patient because she had a stroke, and they're trying to take that clot out. But in real time, as he was trying to take it out, new clots started forming on their imaging. So COVID seems to be causing people to have clots and having pulmonary embolisms and strokes. And so that's definitely a pretty big risk factor. And it's a lot of young people are going in having strokes because of COVID. So yes, definitely COVID. Anything else that might have caused her to have a DVT?
I'm sorry, could you repeat that?
Anything else other than the COVID that might have contributed to her having a DVT?
The medication, maybe?
Yeah, so the Ocella plus her smoking definitely is going to increase her risk. The fact that she was sitting around not really doing anything maybe increase her risk too. So she has multiple reasons why she might have had a clot. And so yeah, this basically was kind of asking for her to have a blood clot. All of those factors together, it's going to significantly increase her risk. So good job.
Thank you.
All right. Okay. So she was diagnosed with a PE and started on appropriate medication. So Dr. Yusra, what medication would you start on her? For the PE?
I would suggest like a blood thinner for anticoagulation, so the clots can like slowly dissipate.
What blood thinner and why?
I'm not exactly sure on what blood thinner I would use.
That's okay. So it's a hard question, and not one that I expect you to know. But something like heparin is what I typically do with somebody that has a pulmonary embolism. Heparin is a blood thinner, just like you say. And the reason why we give heparin, it's not to break up the clot, but it's because your body is always in a balance of breaking up clots and forming them. And so if we're inhibiting the part of that process that is making clots, the body focuses only on breaking them down. So we're preventing new clots from forming, and your body kind of takes care of the ones that are already there. So that's why we do heparin or any other anticoagulation. Now, what if I say that this patient had a blood pressure of 70/30 and oxygen saturation was super low and their heart was beating super fast? What would you want to do instead?
I'm not exactly sure.
So, okay, that's okay. So instead of doing heparin, which is going to just focus on the breaking down, we probably want to do something to take out the clot entirely. So Dr. Paul, what is it that you want to do?
Can you hear me? Sorry. I would say either a TPA if it's like a really big clot that we see on the angiogram, but also that's a little risky. I remember you saying so. If we can't do that, then maybe a catheter to like remove the clot.
Yeah. So TPA is a medication that actually it's a clot buster, so it actually breaks up the clots that are there. But I think I mentioned in one of the videos is that if you are breaking up a clot in one portion of the body, you're going to break it up everywhere. So it is risky because you can increase the risk of bleeding. Now, you mentioned catheterization. So there's two ways we can do that. Either we put a catheter up and inject TPA just where that clot is, so it's more localized, or it's kind of like a Roto-Rooter where we get the clot and actually pull it out. And so, yeah, we can definitely do those two. Someone on YouTube actually mentioned that she's septic. So she is actually septic, which I didn't really realize until right now. So she's tachycardic. Her heart rate is her respiratory rate's up. Her temp is up, and her white blood cell count is low, which is part of the criteria for sepsis. So anybody can answer this. So what's causing her sepsis? Let's go with Dr. Nizzard. What's causing her sepsis?
Maybe her blood pressure, since it was a little low.
Well, that would be kind of like in the spectrum of her sepsis. She's probably in severe sepsis. But what's her source? What's her source of the inflammation? Why is she in sepsis?
Oh, the infection?
The infection. Which infection?
COVID?
COVID. So yeah, she's septic because of COVID. You can sometimes have a bacterial infection on top of that, but it doesn't look like that from the chest X-ray. So she's septic probably because of COVID. And so the patient, does anybody know what we treat COVID with? Or do you know, Dr. Shannon?
No, I don't know.
Okay. Dr. Karina, do you know by any chance?
If there's a bacterial infection on top of the COVID, you would give antibiotics, but for the actual virus, would you just treat the symptoms that it comes with?
Yeah, exactly. So we do it basically symptomatic treatment, and that's about it. Now, there are studies have shown that patients on azithromycin help. That tends to help because it decreases the inflammation of the lungs. The other thing that you can do if they're getting very severe is remdesivir, which is the antiviral medication that shows some promise in the ICU. It doesn't get rid of it completely, but patients have better outcomes. And then Dr. Bailey is saying convalescent plasma. So how does convalescent plasma work, Dr. Bailey?
In convalescent plasma, you're literally giving your patient plasma from recovered patients. I know it was only recently, actually not recently, back in March, FDA approved it for use in more severe patients here, but it's still considered experimental.
Yeah, so the convalescent plasma is basically supplying the antibodies against COVID from other people that had it and recovered to that person. And so so for this patient, she was started on azithromycin for her COVID, and then she continued on the heparin drip while she was in the hospital. Her respiratory status worsened, and and so she was started on remdesivir, but she ended up needing intubation. About a week after in the ICU, she was eventually extubated, so she was able to recover to the point where they took out the intubation, and she ended up recovering well. she's still on oral anticoagulation, so she's still taking medications to prevent clots and to help her body recover from the pulmonary embolism, and she's continuing physical therapy. So yeah, that's what happened with her. Any questions at all before we move on to the next group? So Dr. Chitwan is saying not hydrochloroquine. Hydrochloroquine maybe, but you're right that we tend not to use it as much because it can cause arrhythmias, especially with the azithromycin. Any other questions? She's probably going to stop taking Ocella. A good alternative is like an IUD. So that's a T-like device that's implanted in the uterus, and you don't have that systemic hormone. Would her weight be important here? I don't think it was mentioned as part of the physical exam. Yeah, her weight actually, Dr. Karina, why is her weight important?
So I was thinking that it could confirm a sedentary lifestyle, and that would also confirm that she might have some clogging in her arteries, which could lead to the pulmonary embolism forming.
Yeah, that's not so much the pulmonary embolism, but more for like a heart attack. But her weight is actually really important, and something I didn't bring up, because patients that are overweight have worse outcomes with COVID. So a lot of people that die, that are intubated or in the ICU for a long period of time, they're overweight. So it would be important here. Was the patient intubated when conducting the chest X-ray? I don't think the X-ray shows intubation. So no. Why do we use heparin instead of something like aspirin? Aspirin is an antiplatelet therapy, so they work on two different mechanisms. The aspirin inhibits the way that platelets aggregate. The heparin stops the actual coagulation cascade. So instead of just working on the platelets, it's going to stop the formation of clots so that your body can focus on reabsorbing them. Would we switch her to more progesterone-based birth control? You can do progesterone only. Honestly, the safest one is probably an IUD. It's probably going to be more reliable. Yeah, Dr. Zachariah, obesity for sure. Is that because of pressure on the organs or weight? I think it's more because the inflammatory effects of being overweight. So you're more in an inflammatory state, and COVID kills because of inflammation, because your lungs are in this inflammatory state. Plavix, Dr. Zachariah, is also a antiplatelet therapy, so I wouldn't use it for blood clots, because having the antiplatelet effect is not going to stop necessarily new clots from forming, especially if you have a clot there. It can help a little bit, but you really need to stop that cascade going down. So heparin would be better, but after you leave the hospital, you wouldn't be on heparin. You'd be maybe on Lovenox, which is a different type of heparin that you would inject, or something like Pradaxa, which is an oral anticoagulant. There's also Eliquis and other anticoagulants that you can take. But yeah, any other questions before I move on? And if you do have more questions after this, you can put them on the stream. Make sure that you guys watch the videos from yesterday, at least the last one, so you can kind of get the information from that case, and review case two. And make sure you do the post quiz after you've watched yesterday's, and we're going to talk about the post quiz probably around 2 p.m. Pacific time. All right, you guys take care. I'll hopefully see you guys in a bit when we talk about the quiz. And if you have more questions, you can always jump onto the live stream of the last case and ask questions there. All right, take care, guys.